This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
My name is Deborah Grady. I'm a professor of medicine here at UCSF and a general internist. I'm also the co-director of our Clinical and Translational Science Institute, a co-director of the Center for Healthcare Value, and one of the deputy editors of JAMA Internal Medicine. We have two talks tonight. The first will be presented by Dr. Chris Moriades. Chris is going to talk to you about the principles related to high-value care. He is an assistant professor of medicine here at UCSF and a hospitalist, really focused entirely on hospital medicine. He also directs the UCSF Caring Wisely program, which I think he'll tell you a little bit about, which is focused on trying to improve the value of the care delivered in our hospitals and clinics. And he is director of implementation of costs of care. He's also the author of the recent book that I'm sure he's going to tell you about, called Understanding Value-Based Healthcare.
Hi, everyone. It's my pleasure to be here with you today. So just a quick disclosures. I do get some royalties from McGraw-Hill for the textbook that was mentioned, Understanding Value-Based Healthcare. There you go. That's like $2 right there. And I also get grant support from the ABIM Foundation, who had started the Choosing Wisely campaign, which I'll be telling you a little bit about tonight. So a few years ago, I was in the ICU, getting ready to round on my patients, when I stopped at the doorway of one of my patients and immediately knew something was wrong. He looked at me and he said, "I feel like I'm gonna die, doc." And it kind of looked like he might be right. His sense of impending doom was because he was bleeding. He was hemorrhaging from his stomach. And while most GI bleeds are serious and can be life-threatening, they usually are more of an ooze or a slower flow bleed. But this middle-aged man had actually eroded into one of his arteries in his stomach. So with each heartbeat, he was spurting blood into his stomach. His blood pressure was low and dangerously dropping. His heart rate was climbing, and he looked that cool, pale color of lifelessness. It was dramatic. I stood at the edge of his bed, and I calmly but firmly gave orders. "You, call the blood bank, activate the massive transfusion protocol. Jane, start a big IV." We got the blood there quickly and started forcing it into his veins, keeping up with the losses. And eventually he was whisked away to the interventional radiologists, who were able to inject some dye and take pictures and see exactly where it was bleeding and put a coil in to stop it. A relatively recent but life-saving procedure, an advancement of medical care. It was pretty clear that modern medical care saved this man's life. Medical care can be amazing. And there are very few times that I get to feel like that life-saving doctor I'd fantasized about when I went to medical school. But this was one of those times, and it felt really good. I wanted more of that. It is likely that in decades past, this man would have died, and that in many parts of this world, this man would have died. We were all very thankful for the blood that was donated by some stranger, given to him, that clearly saved his life. How many of you have donated blood before? Wow, many of you. Thank you. Right? You're a hero. You may have saved someone's life like him. But I have to tell you a dirty little secret. It's more likely that you didn't. You see, the vast majority of blood transfusions that I order are neither as dramatic nor likely to be life-saving. In fact, usually when I give someone blood, they can't even tell the difference afterwards. And it gets worse. We know that blood transfusions that are unnecessary cause harms. They can cause allergic reactions. They can cause fluid buildup or injury to the lungs. Rarely, they can cause infections. And these are all very, very small risks. When you need blood, that's well worth it. But when you don't need blood and it doesn't make you feel better, all you're left with are the downsides and the risks and the harms. Imagine you sat there, donated blood, selfless act, gave up your time, your comfort, and yet the blood that was given may not have helped the patient, but even could have hurt them. At UCSF Medical Center, we aim to try to improve this situation. We institute a successful program to decrease unnecessary transfusions to patients in the hospital. At Stanford, across town here, they instituted a similar program in 2010. And 2 papers were recently published in the academic journal Transfusion, showing that red blood cell transfusions decreased by 24% at that hospital. So what happened to the patients? Well, as the transfusion rates fell, they actually did better. Overall mortality went down. Among patients who had transfusions, it fell from 5.5% to 3.3%. Length of stay for those that got blood transfusions also decreased. Fewer patients died, fewer patients stayed in the hospital, and we gave less blood. How could that be? They interviewed an anesthesiologist from Johns Hopkins Hospital when these articles came out, and this was published in Nature this past year. And he said, "I think we were kind of brainwashed into thinking that blood saves lives, and the more you give, the better." This is because most physicians have seen amazing miracles like I saw, patients' lives saved. In fact, although blood transfusions have been around for a while, they really came into their own as life-saving therapies during the World Wars. And so we saw this as a life-saving therapy. But we have now gone 180 degrees, and we think that less is more, he said. This is just one example in medicine of many that we'll talk about where less may be more, where the right medical care, when needed, can be miraculous, and too much of it can result in harm. And that's what we're going to talk about tonight. So tonight we'll briefly explore why and how too much medical care, overuse, and overtesting can be bad. The rest of this course will feature experts. We'll dive deeper into the specific instances, from cardiac testing to antibiotics to even the hallowed physical exam. So I suppose the first question may be, how common is this problem? Is this something we all should worry about, or is it only happening at the margins? There was a survey study published in 2011 where they asked primary care physicians, and nearly half of them said that patients in their own practice were receiving too much medical care. When you go to the emergency department, it gets worse. This was published this past year. 97% of emergency physicians, pretty much all of them except for that one guy, said that advanced imaging studies, CAT scans, MRIs, that they themselves order are unnecessary. And we know, as Dr. Smith-Bindman will talk about in this course, that overuse of imaging, especially CT scans, CAT scans, are associated with lots of downstream harms. We're giving radiation doses that down many years can cause cancer. And so it's not that this comes without risk, but it's done anyways. We know that antibiotics, when given unnecessarily, can lead to dangerous infections. They can cause resistant bacteria, and they can cause infections like C. diff colitis, which is a serious and potentially life-threatening infection. And yet, when we look at acute bronchitis, a condition that doesn't usually warrant antibiotics, 71% of adults with acute bronchitis were prescribed antibiotics between 1996 and 2010. Incredibly, that rate is rising not flattening, not going down, despite evidence showing that antibiotics are not helpful. So this gets us to the fact that as much as 1/3 of all healthcare that we deliver in this country does not make patients healthier. A substantial portion of that unnecessary care may itself cause harm. In 1998, the Institute of Medicine identified 3 categories of quality issues. They talked about underuse, that lack of a necessary medical care is a problem in this country, obviously. So if you're having a heart attack and we don't give you aspirin, that's a quality problem. And that's underuse. Misuse, giving the wrong care, prescribing the wrong treatment, the wrong medication, or perhaps giving the wrong dose. That would be misuse, quality problem. But the third one is overuse, providing unnecessary care. Heart testing for a young, healthy man would be a situation of overuse. And it turns out that over the last 10, 15 years, there's been great strides in addressing underuse. It certainly still exists in parts of medicine and parts of our country, but there's been great strides in reducing underuse. There's been lots of attention on how we help fix misuse. But there has not been as much attention or efforts made when we talk about overuse. So the question is, why? Why do we do this? This is offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm going to order a bunch of tests. There are many different reasons. This could be a talk in and of itself. But in a few years ago, in JAMA, some prominent health service researchers, so Zeke Emanuel, Victor Fuchs, called it the perfect storm of overutilization. And they outlined a number of drivers that have come together, that reinforce each other. These include a physician culture that rewards perceived thoroughness. So it looks like you have an arrow through your head, but I'm going to be thorough. Let's make sure there's not just something else that happens to be going on too. We know that the fee-for-service payment system encourages overutilization. You get paid. The more you order, the more that the hospital or the physician gets paid. And even though we are, I think, almost all well-intentioned, may not be driven by that motivation overtly, we're certainly not, it certainly doesn't cause us to not order things, right? There's no block on that driver. There's direct-to-consumer pharmaceutical advertising. So if you guys watched the Super Bowl, there was a 1-minute ad on opiate-induced constipation. Who do you think paid for that? It looked like a PSA, but it wasn't a PSA. It was paid for by the pharmaceutical companies because they know that you're going to go ask your doctor if opiate-induced constipation treatment is right for me. All of these, and many of these issues, so when you think about direct-to-consumer marketing, when you think about misaligned incentives, usually we have this demand is modulated by cost, right? So we all maybe want to drive a Tesla, but we can't all drive Teslas because we recognize that it costs too much for many of us. And so that helps modulate the demand. But in healthcare, if we're not really paying for it directly anyways, if we have a third party that's going to buy it on our behalf, well then heck, we all want Teslas. And so all of this together helps reinforce this pervasive belief in medicine that more care must be better. That if some care is good, more must be better, newer must be better. But as most clinicians know, that is often not the case. Nearly every test, medication, or procedure has the potential to cause adverse effects. And when you look at this on a national scale, you'll see that patients who live in regions with more intensive care patterns have been shown to undergo more tests, more procedures, more visits with specialists, and have more hospitalizations. So what do they get for all of that more? They don't get better outcomes. It turns out that not only do they not live longer, in many instances they do worse. Not only do they not live longer, but in many instances, they are less satisfied with their medical care. They are less happy with their quality of life. So I want us to think about how this happens. How does more medical care lead to these sort of harms? And there's a number of ways, both direct and indirect. So directly, we know that everything comes with side effects and potential risks. You have an allergic reaction to the blood transfusion, that's a direct harm. A side effect from your medication, that's a direct harm. But there are lots of downstream harms that are less clear, much more insidious, and much more common. So it turns out that more medical care leads to more diagnoses. How can that be a bad thing? Well, because the more things that we find and say is wrong leads to more and more things to do, right? So we find a little nodule in your thyroid, and we say, that's probably not going to ever cause you a problem, but let's go ahead and get another test. Let's go ahead and biopsy it. And eventually, as we add to this, more to do, we add to distraction, complexity. You have 15 minutes to see your doctor, but you now have a list of things to address. You never get to the things that really matter to you. We also lead to labeling conditions that are not actually problems that are gonna cause you harm in your lifetime. But we label it as a disease, we call it a disease, and it makes you feel unwell. Also, we lead to more treatment. And ultimately, what we create is more worry and disability for each of us, more unnecessary treatments, more mistakes. The more we have to do, the more distraction, complexity, more prone to mistakes, more adverse events, and more what we've been calling financial harms for patients. So actual costs coming out of our pockets, both on an individual scale and as a society. In addition, some of the testing, much of the testing that we do, routinely produces false positives, things that are not a problem. So you get an HIV test and they tell you that it's positive you have HIV, but you don't actually have HIV. That happens very rarely, and when you study those people, they have profound, long-lasting psychological and emotional harms from that. More commonly, we get a mammogram, and it shows an abnormality. So what do? You get another mammogram. And then you go and get a biopsy, you get this whole workup. And it's amazing that at the end of the day, we say, it's not cancer, and everybody says, thank God, thank you so much, doctor. And yet we just put you through this whole array of testing and procedures that you may not have benefited from. The snowball effect builds up rapidly. And I think it's nowhere more clear than in our ICUs. I get to take care of patients in the ICU, and as I described at the beginning, I see miraculous things. We save lives in our ICU. But unfortunately, I also see many patients at the end of their lives spending it in the ICU, having invasive therapies, procedures that in some of these instances they never wanted. In fact, when you speak to patients with chronic life-limiting disease, the majority of them say that they'd want to die at home. But many of them don't. Many of them die in the ICU, and this aggressive care can cause further adverse events. It can diminish the quality of their life for their patients and their families for their final weeks or days. It's a serious problem. And so we recognize that the physical and emotional harms of over-testing and over-treatment are clear. I propose that we add to that this idea of financial harm as well. So we advanced this in an article in JAMA, me and my colleagues. We said, first, do no financial harm, talking about the fact that more patients are paying more and more out of pocket for medical care, and that we should consider this pretty much like a side effect of our therapies. And like side effects and therapies, it doesn't mean that we can always avoid it. It doesn't mean that medical care is not helpful or good, but it means we should look for opportunities where we can mitigate. So we point out in the article, some physicians may be resigned to say it's a reality. You know, financial adverse effects, that bill that comes in the mail, that's not my fault. I was just giving you medical care that I needed to give you. But it turns out that when you look at certain things like central line infections, infections from big IVs that we put in for life-saving therapies, sometimes you get an infection and physicians used to shrug their shoulders and say, that's an unavoidable harm. It just happens in a certain percentage. And yet more recent evidence shows that that's not true. That actually, physicians can take actions to avoid almost all central line infections. And we believe similarly that clinicians can help patients avoid these type of financial harms. The easiest way to do it is to not pursue testing and treatments that don't make folks healthier. And this idea really becomes encapsulated in this idea of high-value care. So in the title, you saw high-value care. What this means is encapsulating patient affordability, safety, and experience. In other words, providing the best care at lowest costs. We want to maximize quality, maximize safety, make it a decent experience, not a miserable experience. We want to maximize happiness, but we also want to do it with considering affordability. And that's what high-value care means. So the question is, how can we address medical overuse? There are a number of ways that we can do it. Perhaps the first step is shining a light on the problem. That's what we're doing today. It's also what the ABIM Foundation has started to do with the Choosing Wisely campaign, which has become an international campaign. What Choosing Wisely did was they said, we are going to engage physicians, nurses, healthcare professionals, professionalism, and say that this is a call to first do no harm. And so instead of telling everybody what to do, Choosing Wisely went out and said, you tell us 5 things within your own domain. So cardiologists, you tell us 5 things that cardiologists do. Gastroenterologists, you tell us 5 things gastroenterologists do. Hospitalists, you tell us 5 things hospitalists do. That quote, patients and physicians should question. Not that we should never do, but that you should probably question. And they've now signed up more than 70 specialty societies across medicine to create these top 5 lists. And they've now signed up nurses, nurse practitioners. It's spread to Japan, Choosing Wisely Canada, Choosing Wisely Australia, many different countries. It turns out overuse is an international problem. In Italy, I love, they don't have Choosing Wisely exactly, because they're Italian, so they have slow medicine. How Italian is that? And patients, the community, is a vital component of this message. And so what Choosing Wisely did was they teamed up with Consumer Reports. And they're putting out resources directly to consumers, to patients, to the public about these topics. And you'll find blood transfusions for anemia in the hospital. Why sometimes you don't need it. On my doorstep, not as a physician, not as someone who's part of Choosing Wisely, but just as someone living in San Francisco, I got imaging tests for low back pain while you probably don't need that X-ray, CT scan, or MRI. So they're making an effort. And these are available for free, either on the Choosing Wisely site, choosingwisely.org, or on Consumer Reports. In our professional journals, we've had a number of efforts to increase visibility of this. So JAMA has a patient page, and recently they had a page on high-value care. And they pointed out what can patients ask their physicians to increase high-value care. They said to ask, what are the risks of the tests or treatments? How will this test or treatment help me? Are there any other options beyond what was just recommended? And what would happen if I do not do anything? Starting those conversations helps physicians, nurses, patients avoid over-testing and harm. Let me tell you another quick story about a patient. So this 55-year-old man had just a history of high cholesterol, and that was it, pretty much healthy. And he went to his primary care doctor and said he had persistent sinus congestion. It was the late fall season, and he said he had a cough and a runny nose for the past 7 days. They said, oh, you just have a little sinus infection. That should go away on its own. Let me just give you some decongestants. But then the doc was like, well, it won't hurt. Here's a prescription for an antibiotic just in case. Here's azithromycin, Zithromax. Take it if you're not feeling better in 2 days. So 2 days later, of course, he's like, I still feel pretty crummy. He started taking the antibiotic. 2 days after that, he started to notice that he was having some swelling around his lips, pain when he tried to swallow. It started to get worse. He started having some worsened rash. He actually got an ulceration on his penis. That was scary. So he went to the ER. He was having a fever, and he had crusting around his lips and this rash swelling around his eyes. He's having what's known as Stevens-Johnson syndrome, a fairly rare but very serious reaction to medications. He was hospitalized, just given some IV fluids and supportive care, and luckily did better after 3 or 4 days in the hospital. Here's the thing. Telling these stories, I think, are important because we need to change that thought of, well, what's the harm? Here's an antibiotic, maybe it will help. And so we've created a forum for that in JAMA Internal Medicine, who's co-sponsoring this series called Teachable Moments. I'm one of the editors with Deb Grady, Dr. Grady here, for Teachable Moments. And what we do is we empower trainees, medical students, residents, fellows, nursing students, pharmacy students, to tell us stories that they saw from the front lines. But importantly, we match those anecdotes with actual evidence and data, right? So we match it with the teachable moment where you go through and you say, why didn't this patient need antibiotics? What is the evidence? How often does Stevens-Johnson syndrome occur? Matching stories with evidence is a powerful way to capture both the hearts and minds of clinicians and all of us. It's something that if you think about it, people like Dr. Atul Gawande do to great effect. Stories and evidence. And it's something that we've done through our nonprofit called Casa Care, looking at the costs of medical care. And over the last few years, we've collected more than 500 stories about how medical costs have harmed patients. We've collected them from patients and caregivers, and we're putting a face on the problem. Because as we like to say at Casa Care, most physicians don't go to medical school to treat the gross domestic product. We don't treat the GDP. We treat the patient in front of us. And so we need to make this about our patients. With Casa Care, we created a textbook, a resource called Understanding Value-Based Healthcare, written primarily for physicians and nurses and medical students, but hopefully written in a way that's accessible to anybody who has interest in this topic or interest in healthcare. And as you'll also hear about more throughout the course, the Center for Healthcare Value at UCSF is really focused on becoming a leader in academic medicine to reduce costs, increase value, and enable innovation through efforts like research and policy, which you'll hear about from Dr. Dudley, through training, by training at every level of clinicians, and through our delivery systems, where I help lead a program called Caring Wisely, where we're trying to implement the ideals of choosing wisely. Right? So how do we actually deliver that care? How do we actually decrease transfusions in the hospital? And that's what we've been focusing on. And lastly, there are many national programs. So this is all sort of what can you do, what can we do? But just so you know, there are tectonic plates that are moving on a national level to change this and drive clinician behaviors. The CDC have started antimicrobial stewardship programs and have recommended that all hospitals, all clinics have programs to look at antibiotic overuse and try to help curb that problem. The American College of Radiology have created appropriateness criteria for imaging studies, guidelines for patients, which you'll hear about from Dr. Smith-Bindman during this course. The FDA has now started a program to decrease unnecessary radiation exposure on a scale across the country. And the Affordable Care Act has put in motion some national payment reforms that are help spurring things like accountable care organizations and bundled payments to try to help curb that fee-for-service program that leads to more testing and more care. So in conclusion, medical care in the US suffers from widespread overuse and underuse. There are areas where we're not giving medical care that is needed, but right now there is a big problem of overuse, which leads to countless direct and indirect harms, many of which will be discussed throughout this course. So this was really just meant as a broad overview. You will dig into the concrete specifics. High value care means balancing quality, patient safety, experience, and costs. In other words, providing the best care possible at the lowest possible cost for patients. And confronting such a large problem is going to take all of us. It's going to take big systemic changes. It's going to take policy. But like the environmentalism movement, it's going to take all of us, right? We don't just sit on our hands and wait for policy to change or for them to change manufacturing in China. We all take personal responsibility and we change our own behaviors. And so that is what we're looking to do, to curb medical overuse as an important responsibility for all of us. So thank you. That's my overview. And I'll welcome questions. Yeah, that is can we start with an easier question? Yes, so that's a fantastic question about whether what physicians may be able to do about overuse in situations where patients are not the primary decision makers, so when they perhaps are critically ill, and that there's evidence of that patients are willing to undergo necessary care or invasive procedures for the benefit of their family members in those type of situations. And lastly, are medical students, trainees taught about how to communicate this? Did that capture it? I believe so. So a lot there. I think basically training is a major lever there. So how do we address it? That's, I think, one of the most important things we can do is start to talk about how we have these type of difficult conversations, to start to teach our future physicians and nurses to recognize harmful overuse, to understand the different motivators and family dynamics and cultural dynamics, frankly, that we confront that all play into these values and issues. And to be able to have those conversations with family members and to remind them that our responsibility in a patient who can't make their own decisions is to really keep their best interest in mind. And so it's not an easy problem. I don't know, but I think that you touched on important things, communication and really teaching people how to have that communication. In my mind are some of the most important ways to do that. I've noticed when I spend time with family members and we really sit down and we reflect about what is our ultimate goal? What are we trying to do for your dad, your mom? We can oftentimes come to a much better understanding and explain why I worry about them staying in the ICU and getting these procedures and what's going on. So that's how I think I would address that. Yes, sir. Yeah, great question. Question about pay for performance, which, as you mentioned, sounds like a no-brainer, right? Yes, we should be paid to do better. Pay for performance, pay for quality. And yet, what are the potential downsides? What is the evidence? The evidence has been quite mixed on pay for performance. There were some initial studies that showed that it really did improve some quality measures and outcomes. And then other recent studies that showed that really it didn't make that big of a difference. And there are many potential downsides. One is that there's a pithy comment that people often make, which is that not everything that matters can be measured, and not everything that's measured matters. And the problem with pay for performance is we have to measure performance. And how do we do that? Well, we pick the things we can measure. So it's like the old story of the drunk who's looking for his keys under the street lamp. Why was he looking there? Because that's where the light was, right? And so if we're looking there because that's the only place that we can illuminate, we're missing the big picture. So we look at things like 30-day readmissions. Like if a patient gets readmitted on day 31, it's not an important outcome. And we focus on that. And so part of the downsides is this playing to the test, this focusing on specific problems while missing big pictures like how are we having those communications, what are we doing? There are other issues about how big should the payment be, what percentage. It needs to be big enough to compel people, but not big enough that it compels people to game the system or to cheat. So there's lots of unknowns. I think the general consensus at this point is that pay for performance is a good idea. We haven't figured out how to do it well. And so I think that's where we will go. People will not just be paid to do more, they'll be paid for some sort of quality, but we need to work out a lot of the knotty issues of how are we going to measure that quality? How are we going to assure that we're providing the right motivation and that we're not sapping the intrinsic motivation of our hardworking physicians and nurses and others? Mm-hmm. So great point made about whether we should be looking at the palliative care model to give us some lessons about both, it sounds like, stepping back and understanding, first of all, patients' actual understandings and wants from their medical care, which I think is a big part of providing high-value care, right? It's a bit orthogonal to what you're saying, I think, but I'll use it as an opportunity to point out that it made me think of in studies where if you ask the doc whether their patient wants antibiotics, oftentimes the doctor will say, yes, of course they do. They came to the emergency room with a sore throat. That's what they're here for. And it turns out if you actually ask the patient, they say, no, I don't necessarily want antibiotics. I just want to be told what to do. So there's a disconnect, as I think you were pointing out oftentimes, between sort of what our understanding of what the patient's actual goals and wants and desires are. So it gets back again to that idea of communication, opening up conversations with patients that are frank and that are understanding their goals and patient preferences and experiences. Great question. So the question was about if quality metrics are so limited, are there attempts to use stuff like, say, surveys for specific conditions to help create measures? And the answer is absolutely. There's a lot of research and effort going into creating what some people call patient-reported outcome measures, or PROMs, P-R-O-Ms. Patient-reported outcome measures is exactly that in a way. You ask patients about their outcomes, and we ask them what is it that matters to them. So when they get a knee replaced, what are we being measured on? Well, how long did they stay in the hospital? How much did that cost? Did they get readmitted within 30 days? But what does the patient care about? They care about if they can walk up the stairs. So we want to start asking them about whether or not they are happy with their care. And we can look at outcomes like, how is your functional status? Can you walk up the stairs? And so I think there are a lot of efforts to do that, but as you can imagine, determining what those measures are, getting those out, getting buy-in to that, getting patients to feed that information back is fraught with challenges. Great question that comes down to how can physicians protect themselves against malpractice?
How can the community protect our doctors?
Oh, even better. How can the community protect the doctors? I love that. That's perfect. No, it's a great point, and I want to point out that what is called oftentimes defensive medicine, which are physicians ordering procedures and tests because they want to avoid being sued, is seen as a major driver of overuse. And certainly when we talk to physicians, many of them see it as their primary driver for overuse. It's a little unclear, to be honest, what we can do, unfortunately, because when you look at places that have had pretty significant tort reform, physician behaviors didn't actually change. And when you look at being sued, it turns out that although physicians think ordering more tests is going to avoid being sued, there's very little evidence that that's true. Most of the evidence shows that the only way to avoid malpractice is having conversations, actually, so speaking with patients in depth and documenting what was said. How can the community protect? I mean, I think it's a great question. I think that thinking about how we can create a system that achieves the goal that malpractice is meant to achieve, although fails to, which is to protect patients from malicious actions, creating that system is challenging.